Welcome to Medical Grand Rounds. Is this on? Okay. Real pleasure today to introduce Tom OConnell, one of our own, who's going to give our last Grand Rounds for the summer, and then we'll resume, I think it's either the last Thursday in August or first Thursday in September. Tom, many of you know, has been here on the faculty for 4 years, about, in September. He has an outstanding background except for 2 years of questionable judgment where he was working at another institution, but he overcame that nicely. I was thinking he was originally from North Carolina, but now he tells me he's a damn Yankee, but did move here in high school and went to Notre Dame, and then for undergraduate went to medical school here, did his internal medicine in Cincinnati, came back here for endocrine fellowship. As many of you know who've interacted with Tom, he's a very academic and thoughtful individual who also is a terrific clinician and teacher and has been a great addition to our group in endocrinology. He's going to talk about a topic that I'm interested in hearing about because it seems like it's been swinging back and forth lately about glycemic control in the hospital. And I'd just like to thank Tom for presenting today and look forward to his talk.
Boy, I sound pretty good. All right, so I'm going to talk about diabetes control in the hospital, and I'll get to why I'm doing this. Can you guys hear me? I'll get to what sort of got me to doing this talk in a minute. But first, I'll talk about a case, and then we'll talk about, inpatient hyperglycemia overall, some recent and not so recent clinical trials looking at inpatient control, what our current targets for glucose control are, and then I have a whole section on sort of special populations and how to do diabetes in the hospital in those people, and then a summary slide or two at the end. So my case is actually a patient of mine he had a long history of type 2 diabetes and associated high blood pressure and high cholesterol. And when I saw him last June, and I'd been seeing him for probably 2 years or so, and I had him on a nice basal bolus regimen with high-dose Lantus. He was on 80 units of glargine once a day, and he was taking Aspart 20 units with every meal, and he knew to add extra insulin if his sugar was high. And his A1C, he's this guy, he wasn't the most intelligent guy. He sort of just did what you told him. And he was a farmer from the northern part of the state. And I never got him under 7, but, for what he was doing, I thought it was pretty good to have him at 7.2. So then he was gone for 3 or 4 months as routine, and he came back in October of '08, and his A1C was 9.8. And I'm sitting there, I pull him up on the computer, and I'm about to walk in the room, and I look at his papers, and we do the point of care A1C testing there, and I see that his A1C is 9.8, and I'm like, what the heck happened? And that's exactly what I said outside the door. What happened? And when I walked in, I said, what happened? Well, what happened to him is that he got admitted with chest pain in July or so, or August. He actually had a non-ST elevation MI, and when he came into the hospital, what did the inpatient service do? Well, they automatically cut his glargine in half, so instead of 80 units, he's on 40 units, and they stopped his mealtime insulin and just put him on sliding scale of Aspart. And so when I went back and reviewed his chart, almost every glucose in the record for his 3 to 4 day hospital stay was over 300. And then the worst part is that they sent him home on 80, they bumped his Lantus back up to 80, but they sent him home on sliding scale. And him being a compliant patient, he didn't do what he was doing before. He just stayed on this sliding scale that he was on. So when he came back to see me that day, his sugars were all 2 and 300s again because he was given bad advice on leaving the hospital. It's just a shame when something like this happens, and he's not the only person. So when this happened around the same time that one of our faculty members, Susan Braithwaite, who did a lot of inpatient diabetes, was leaving us. And so it got me thinking and sort of made me decide to try and make a change in the hospital to try and get glucose control better. So as some of you know, starting next month, the endocrine service is going to have sort of this new diabetes management service that's going to be much better staffed than it has been in previous years. And we're going to make a big effort to try and improve glucose control in the hospital. So that's sort of the background of why I'm here today, because we're going to start in July, and so I want to heighten everyone's awareness about diabetes and glucose control in the hospital. So if you want to look at how common it is to have hyperglycemia in the hospital, this is actually a good study. It was just an observational thing where they looked at 2,000 people who came in. Oh, I'm sorry, I'm one slide ahead of myself. In general, if you look at people who are admitted to the hospital, the non-critically ill medical surgical people, about over a third of them will have hyperglycemia. If you look in the intensive care units, depending on where you look, anywhere from 29 to 100%. But really, if you look at tight glucose control, which has been the norm for the last probably 6 or 7 years since a couple studies came out in the late 90s and early 2000s. If you want to look at 110 as the cutoff, basically everyone in an ICU setting is going to have 1 or more sugars over 110. A third of them are going to have sugars over 200, and overall the average in more than a third of them is going to be over 145. This is the study that I jumped ahead to, sorry. So this is actually this guy Guillermo Perez, who's down at Emory, looked at a local hospital in Atlanta and said, okay, of all people coming into the hospital, they followed 2,020 patients coming into the hospital to see what their blood sugars did. 64% of them had normal glycemic control while in the hospital, and by normal glycemic control, they had fastings below 126 and random blood sugars below 200. 26% of them had, 36% of them had hyperglycemia by one of those two criteria. 26% of them were already diagnosed diabetics, and 12% of them were not diagnosed diabetics. And when I looked at mortality of the people with normal glucose control, the mortality rate was 1.7%. In the diagnosed diabetics, the mortality rate was 3%, and in the new hyperglycemia, the mortality rate was 16%. And who composed this group of new hyperglycemia? Some of those were people who had diabetes but just hadn't been diagnosed yet. Some of them were just sicker folks who they were on steroids or they were on IV dextrose or just sicker, but they clearly had a higher mortality than the other two groups. And this is sort of a common scenario that you'll find across the literature. The higher the blood sugar is, the worse your outcomes are. So these studies that we're talking about now are observational studies. But if you look at community-acquired pneumonia admissions, as you go up in glucose, your mortality goes up and your hospital complications go up. Hospital complications meaning length of ICU stay, length of ventilation or need for mechanical ventilation, intercurrent infections. So all these things tend to go up the higher your blood sugar is. In the ICU, observationally, you see the same thing. And in CABG patients, there's a lot of data out there about post-cardiovascular surgery in diabetic patients. But again, you see the same thing. So as your blood sugar goes up, so does your mortality rate go up. And a lot of the other complications in this study, too, are higher. So 2 times length of stay if your first post-op glucose is over 200, 3 times length on the ventilator, and a 7-fold increase in mortality if your first post-op glucose is over 200. So a lot of hospitals have, the CT surgeons are actually ahead of the medical field in this regard because they, years ago, adopted strict policies of monitoring glucose in the OR, and if that person's blood sugar goes above a certain level, they'll put them on a drip right then and there to keep these blood sugars down. And there's other studies that justify that as well. So the observational studies basically show there's a link between hyperglycemia and poor clinical outcomes. Hyperglycemia in the hospital is common, but we all know that observational studies don't really prove cause and effect, and so you need more randomized trials to say that there really is something associated with the glucose and it's not just a marker of poor outcomes. So the first study that we had that looked at that is the Glycemic study, which was published a long time ago, 1995. And here they took people who had diabetes and were coming in with an acute MI. And there were 620 people in the study. They randomized them to insulin therapy versus conventional therapy. The intensive therapy got IV insulin for the first 24 hours and then subcutaneous insulin for the next 3 months. And most of that was a multiple daily injection regimen. Their target glucose was 126 to 180. And actually at the time of entry into the study, the first blood sugar average was 280. At 24 hours, the blood sugar average was 177 in the insulin group and 211 in the conventional group. And then at the time of discharge, the average was 144 and 177. At the end of the first year, the A1C difference was 0.6%. Between the two groups. But at the end of 1 year, there's a 29% reduction in overall mortality, and at 3 years, there was still a 28% reduction in mortality. So a lot of people adopted, well, let's do aggressive insulin therapy after MI in our patients with diabetes. Another good study that again, cardiovascular surgeons did is the Portland Diabetes Project. So they took people, 2,467 consecutive patients with diabetes who were coming in for open heart surgery between January of 87 and November of 97, and they randomized them to sliding scale insulin versus a more aggressive insulin with IV insulin. And their main outcome was deep sternal wound infection. And the reason they did that is because there's such a big gap. Historically, there's been such a big gap in deep sternal wound infections when you look at diabetic patients versus non-diabetic patients. And this is a very costly thing. And I don't have the numbers with me, but I know that making an intervention like this saves the hospital millions of dollars every year in infectious complications costs. And so what you could see is they implemented this IV protocol, and as they got good at it after the first couple of years, you can see that the deep sternal wound infection rate really approached the deep sternal wound infection rate in the non-diabetic patients. So the next study to come out, which you may or may not have heard of, in the diabetes world we've heard of it, is the Leuven-Sicu study. And this was done by Greet Vandenberg in a city, Leuven, Belgium. So it was all done at one site. And she looked at people coming into the ICU, 1,548 of them admitted to a surgical ICU requiring mechanical ventilation. And she randomized them to tight glucose control versus conventional therapy. Those folks only got IV insulin if their blood sugar was over 215, and their target level was 180 to 200. Their mean daily blood glucose at the end of the study was 153. The intensive group got IV insulin if the blood sugar went over 110, and the target blood sugar level was 80 to 110, and the mean daily blood sugar in that group was 103. And so there's some pretty astounding results. They had 34% less mortality in the ICU, 46% less sepsis, 41% less need for dialysis, 50% less need for blood transfusion, 44% reduction in ICU neuropathy. So people, again, thought, well, we really need to do a good job of getting these critically ill patients tightly controlled. There were some flaws in the study. It was done at one center. People will say that this investigator, Vandenberg, basically spent the entire study in the surgical ICU and was managing all these drips herself personally to keep tight glucose control in these folks. They also had a higher than expected mortality in the conventional group. So, but people still adopted this as a pretty, as a pretty routine matter of fact that now we need to get our ICU patients' blood sugars average under 110. But remember, this is a surgical ICU, and so people would say, well, what about medical ICU patients? That's a different cohort of patients. Do we need to do this with them? Most of the time, people would say, well, it's been proven in surgical patients, we probably should just go ahead and do it in our medical patients. And there's been not just these couple of studies that I've talked about, there's been a whole host of these studies that have shown reductions in mortality and reductions in outcomes in tight glucose control. Until in 2006, the first study that came out that sort of muddied the water a little bit and said, well, maybe it's not necessarily true, was the Leuven-MICU study. So same investigator, same institution, now looking at the medical ICU instead of the surgical ICU. And in this trial, she randomized 1,200 patients. They only wanted people that they thought were going to need at least 3 days of intensive treatment. They randomized them the same way to conventional, where they only got insulin if their blood sugar was over 215 and their target blood sugar was 180 to 200. And the intensive group, they got insulin, IV insulin if their blood sugar was over 110, and their target was 80 to 110. The average in the conventional group was 160. The average in the intensive group was 105. And So they had 605 people in the conventional group and 595 in the intensive group. 381 were there for 3 days or longer, and 386 were there for 3 days or longer in the intensive. And the reason that I showed this slide is because there was a difference in the outcomes in the overall population versus the 3-day population. So the primary outcome was in-hospital death. Secondary outcomes, mortality in the ICU, 9-day mortality, days to weaning the vent, a bunch of secondary outcomes. And what you saw, I'm having a hard time seeing this, is that there was less deaths in the overall intention to treat group. There were less deaths. So there was 162 deaths in the conventional group, 144 deaths in the intensive group, but the p-value didn't meet statistical significance. So here's where the reason I said, if you looked at only the people who were in the ICU for longer than 3 days, there was 145 deaths in the conventional, 121 in the intensive, and this p-value was 0.05. If you look at other things, you also reduce need for renal replacement therapy, time on the ventilator. You reduce a lot of secondary comorbidities by doing the intensive treatment group. So again, people said, well, and here's just a graph of what happened. So you have a trend here in the overall group, and you have more of a trend here in the group that was 3 days or more in the ICU. But when you looked at the other things, weaning from mechanical ventilation, discharge from the ICU, discharge from the hospital, the intensive group always did better than the conventional group. Of course, if the primary endpoint doesn't meet statistical significance, I don't know if any of these do, so the statisticians out there can debate that. But this was what was published. So their conclusions were that intensive insulin during the ICU stay prevented morbidity, but did not significantly reduce mortality in all patients. In patients in the ICU for 3 or more days, both morbidity and mortality was reduced. So it's sort of it was a positive and a negative study because it didn't do it in everybody, but in a subset of patients, it did seem to be beneficial. So then the next group of, so people didn't really change their policies. You know, they still said, okay, well, we've got this good data from the surgical ICU. We've got so-so data in the medical ICU. We probably ought to still be shooting for really tight glucose control in these critically ill patients. And then came out just in March of this year, the normal glycemia in intensive care evaluation survival using glucose algorithm regulation. And I like an acronym, the Nice Sugar Study, which is pretty good. So what they did is they took they randomized people from 42 sites, mostly in Australia and New Zealand, large numbers of patients, so 3,000 in each group were managed to intensive treatment, were randomized to intensive treatment with a goal blood sugar of 81 to 108, and then conventional group where the goal glucose was 180. So in this group, insulin got started if it was over 180 and weaned and stopped if they fell below 144. Their baseline characteristics were the same. Boy, these are hard to see. And the thing, can anybody read that? So what you saw is that there was actually more deaths in the intensive group. So this is a study that kind of surprised everybody out there, because not only was it not a positive study, meaning that you reduced mortality with intensive control, you actually increased mortality with intensive control at 90 days. The only other difference in all the outcomes they looked at was hypoglycemia, and severe hypoglycemia with hypoglycemia less than 40. And that was obviously significantly more common in the intensive group. Some of the naysayers to this study say, well, if you had more death, why weren't there any other endpoints that were different? So there was no difference in ICU stay. There was no difference in mechanical ventilation time. There was no difference in infections. There was no difference in length of hospital stay. No difference in need for renal replacement therapy. So why, without any other marker, why is there an increase in death? The only marker that was disparate was the hypoglycemia. The other thing is that the average blood sugar in the two groups wasn't that different either. So it was 115 in the intensive group and 144 in the control group. But again, it's a large study, and it did have a hard outcome, a hard endpoint that was statistically significant, which was more deaths in the intensive group. And so here you can see the intensive glucose control had less survival at 90 days than the conventional group.
So their conclusions were intensive glucose control increased absolute risk of death at 90 days. Severe hypoglycemia was significantly more common in the intensive group. So it's just like a lot of things in medicine, the pendulum swings back and forth. And this is there was so much data early on. Why all of a sudden are we getting data that's the opposite? And I don't have an answer for that. I don't know that anybody does at this point. One thing that I like to say is that, in the earlier studies, the control group's glucose was much higher than now. And, in today's world, you can't get it by an IRB to let the control group sit at 200 or 220 because of all the earlier data. And so the gap between the glucoses in the intensive group and the control group has significantly narrowed. And that may be one reason why, we're not seeing the same results that we saw before. Doesn't explain why we had a complete opposite with higher mortality in this one study. So what I think people have thought is, well, maybe we just don't need to be quite as tight. And so just earlier this month, it was published, it was released online a couple of months ago, but it was published in Diabetes Care earlier this month, is the new ACE, American Association of Clinical Endocrinologists, and American Diabetes Association consensus statement on inpatient glycemic control. So what they say now is in critically ill patients, insulin therapy should be initiated for treatment of persistent hyperglycemia starting at a threshold of no greater than 180. And the difference here, the old ACE algorithm was 110, or the old ACE guideline was 110, the old ADA guideline was 140. And a glucose range of 140 to 180 is recommended for most critically ill patients. Again, they wanted, in the two older guidelines, you wanted everybody under 110 or everyone under 140. And the other thing they went on to say is that IV insulin infusion is the preferred method of maintaining glycemic control in the ICU setting. And they say with a validated protocol. And later on I'll talk about insulin drips, but today's insulin drip protocols are much better than 10 years ago drip protocols where it was, one column. Now you have multiple columns that you can adjust and jump back and forth between the columns to better fit your patient. In non-critically ill patients, the 2009 guidelines say the majority of patients treated with insulin, pre-meal goals should be less than 140, and random glucoses should be less than 180. A difference from the old, which was less than 126 with the ADA, and this actually still was less than 180 with the ADA. But they do say that some of your patients who come in and are already, they're on multiple daily injection regimens or pumps out in the real world, who have much better control than this in general, you shouldn't loosen up control if they're doing well with their current control. They went on to say scheduled subcutaneous administration of insulin with basal, nutritional, and correction components is the preferred method, and prolonged therapy with sliding scale as the sole regimen is discouraged. So we'll talk about that as we go along. So what do you do as an inpatient? Well, most of the time as an inpatient, you stop the oral agents. The sulfonylureas have, they're going to increase the risk of hypoglycemia. Patients often aren't eating when they first come in. Metformin, you don't know what's going to happen with their renal function or if they're going to get hypotension or CHF. It's got some GI side effects. So usually you don't do that. If they're going to get any kind of contrast studies, you can't use the metformin also. The TZDs, because of the instance of fluid overload, CHF, and because they take so long to work. So you can bump their TZD, but you're not really going to see an effect on their blood sugar for weeks or a month or more. So none of these things are great for in-hospital management. If you look at how insulin is secreted by the normal pancreas, both in and out of the hospital, I always tell, and I draw this little graph, a simplified version of this graph for my patients all the time in clinic, that the pancreas secretes insulin in two fashions. So it leaks out a small amount of insulin all day, every day, the basal insulin, and that's this down here. And then whenever somebody eats, it releases a big load of insulin to cover the food, and that's what these spikes are here. And we can mimic that pretty well in today's world with the current insulins that we have. And so this is actually, again, just showing the difference when people are in the hospital. So a healthy person, they've got their basal requirement, they've got their prandial or food requirement, and then a little bit of correction on top of that. And usually the prandial and the basal is about a 50-50 split. If somebody is sick, but they're still eating, the total amount of insulin often goes up, but the ratio of 50-50 stays about the same. If they are sick and in the hospital and not eating, but most of the time if they're going to be here in prolonged NPO status, they're going to be getting parenteral nutrition or IV dextrose, but all these things go up again, but you may actually lose the 50-50 ratio here. But for most of the people that are on the medical surgical floors, not the ICUs, you want to come close to a 50-50 ratio. Most of us that look at these things know that sliding scale alone doesn't work. So this is actually an old article from 1997. They just looked at people coming in the hospital, and the people who were treated solely with sliding scale were 3 times more likely to have a blood sugar of over 300. 80% of the patients in this cohort, the insulin orders were never changed after admission, despite continued poor control with high blood sugars. So this guy, Guillermo Amperas, again, he decided to do a better study that's randomized to look at sliding scale as compared to basal bolus therapy in the non-ICU patients, but the general floor admission patients. And this was published in Diabetes Care in 2007. And the name of it is the Rabbit-2 trial, which I think is another good acronym. So what he did in the people randomized to insulin, basal bolus therapy, he stopped their oral anti-diabetic drugs, and he started them on total daily dose based on their weight and based on their, based on their weight and based on their admission blood sugar. So their blood sugar was 140 to 200. He did 0.4 units per kilogram per day, and if they were 200 to 400, he did 0.5 units per kilogram per day. He used half the dose of insulin as basal insulin and half as rapid-acting insulin. And the basal insulin was given once a day. The rapid-acting insulin was given in 3 divided doses before meals. The thing about this study was he really gave the sliding scale group the best chance of success that he could give them. So, and the reason I say that is because he had 3 different sliding scale protocols to choose from. And so people got started on the usual protocol, and if their blood sugars were still too high, then they got moved up to the insulin-resistant protocol. So to try and combat these high blood sugars that you often see with sliding scale, he said, okay, well, we can use a heavier sliding scale. On the flip side, if somebody was on the insulin-resistant protocol and they were having some hypoglycemia, he moved them down to a less aggressive sliding scale. And so he actually had a dynamic sliding scale, whereas most of the time in the hospital, the sliding scale gets written and the sliding scale stays the same. So this was a little bit, it was a little bit more set to make sliding scale look better or have a better chance of success. The other thing he did is that he gave people sliding scale at bedtime, and a lot of times in the hospital, people just don't give sliding scale at bedtime no matter what. And so he didn't give the full dose at bedtime, but he at least gave half the dose so they had a better chance of not being hyperglycemic again the next morning. Now what you saw with the blood sugars in this trial was the sliding scale group came down some because you're obviously giving them insulin, but the basal bolus group came down much better, and they ended up below 140 for the most part. And if you look at overall success, so 66% of the patients on the basal bolus regimen had goal blood sugars less than 140 versus only 38% in the sliding scale. And 20% of the patients on sliding scale actually had to be converted to basal bolus because they failed, because they never actually attained even close to control. And so you can see here when they switched over, their blood sugars improved dramatically as compared to what they were doing on the sliding scale beforehand. And the big difference between the 2 groups is obviously the basal bolus group got much more insulin than the sliding scale group. Remember, the sliding scale, you're always playing catch up. So that's the main difference. And what's everyone's fear in the hospital is hypoglycemia. The reason that we let people run with sugars in the 300s and 200s is because we don't want to risk them getting into the 40s and 50s. So doing a scientifically calculated basal bolus regimen, what happened? Well, of 1,005 blood sugar readings in the basal bolus group, there were 2 patients that had a blood sugar of less than 60 during the entire trial, and only 4 blood sugar readings total were less than 60. No blood sugar readings less than than 40. In the sliding scale group, 2 patients had a blood sugar of less than 60, and only 2 blood sugars were less, and there was only 1 each, and no blood sugars less than 40. So doing a basal bolus therapy the right way does not necessarily increase your risk of hypoglycemia, and I think that's the fear that everyone has and why people are resistant to doing it. That, and it's a little, it's a little tougher. You have to think a little bit more rather than just write generic sliding scale orders. So how do we do insulin in the hospital? There's lots of reasons that you would use IV insulin on people. Obviously, DKA, hyperosmolar state, critical care illness. So we use IV insulin a lot in the hospital, and I think we all know that. You guys all know that. And this is what I was talking about before, having a protocol that's, something that titrates to fit the actual patient, because your 350-pound, hugely insulin-resistant person is not going to be served by the same protocol as the 110-pound thin type 1 diabetic. And so today's protocols will actually have 3 or 4 columns where, based on the patient's response to a given insulin dose, you can then not just move up or down within the column, but you move over a column to really jump or change the doses. And so that allows you, instead of having glucose patterns that look like this, to have glucose patterns that look like this on a good protocol. So when you transition somebody from IV insulin to subcutaneous insulin, there's a couple ways to do it. I like to, one good way to do it is to look at the total daily dose over, or the average insulin dose over midnight to 6 a.m. If your person's not eating, not on tube feeds or continuous tube feeds, that can be looked at as purely basal insulin for the most part, if they're not on dextrose either in their IV fluids. And then you can actually make a calculation to figure out what their 24-hour total daily basal dose would be, and then you could give them, and a lot of times we shoot for, this says 80% of what you think their total daily basal dose is, just to make sure that you don't bottom them out at the start. Of course, you're going to be looking at your patient every day and adjusting it up if you need to. So this 80% just make sure that you don't get hypoglycemia during that time. If somebody was getting tube feeds, then you say, okay, I'm going to make a calculated amount that's not their 24-hour basal, but their 24-hour total daily dose. And then you're going to go through the calculations of dividing the total daily dose into 50% basal and 50% nutritional. So again, in the hospital, and actually in the outpatient setting, there are sort of 3 components to insulin. There's the basal insulin, there's nutritional insulin, and then there's correction therapy. Notice that doesn't say sliding scale. We sort of talked about this. Well, another way, if you don't know, so say your person isn't coming in the hospital the person's not going to the hospital, they're not on an insulin drip, they're just coming in, you're stopping their oral agents, and you want to put them on subcutaneous insulin. And so you can do that based on body weight. So if they're thin, or if they have other things like they're on dialysis or hypoglycemia risk factors, then you might use 3.3 units per kilogram. 0.4 units per kilogram in a normal body weight person. If they're overweight, 0.5. If they're obese, or if they're on steroids or something like that, you might use 0.6. So that would be their total daily dose. Another way to do it is if they are on 70-30 as an outpatient, you can add up their total daily dose and then take 50% of that and make it basal, and 50% for their mealtime. And then again, you could do it based on what their infusion rate was. And here we go again. So 40 to 50% should be basal in general. The remaining 50 to 60% would be divided evenly among their food to cover their caloric intake. The nice part about this is if you've got them on their basal insulin and they become NPO for whatever reason, then you can just stop their nutritional component. You can say hold the scheduled 6 units of aspart if they are going to be NPO. You can always still give them their correction insulin, but you just hold it when they become NPO, the mealtime part. So this is somebody eating regular meals. 50% of their total daily dose is basal, and there's different ways to do it. Most of the time nowadays we use a once-a-day basal insulin. Historically, a lot of intermediate-acting insulin, like NPH, was used, and you can either do 50% in the morning, 50% in the evening, or 2/3 in the morning and 1/3 in the evening. And then you would use 50% of their total daily dose as mealtime insulin, so rapid acting before breakfast, lunch, and dinner, or regular before breakfast, lunch, plus minus dinner. The reason that says, breakfast and dinner plus minus lunch, the reason that says plus minus lunch is because if they're on intermediate acting insulin, the NPH is going to have some peaking effect at lunch, and so you have to be careful, and you're not going to necessarily have the same doses throughout. And then you're going to always give correction insulin on top of their prandial insulin. So this is what the insulin requirement looks like in people who are eating, and they eat and maybe they have a bigger breakfast here than their lunch here, and then a bigger dinner than both of those. And so we can mimic that, like I said earlier, with our insulins today, with a shot of long-acting basal insulin and then mealtime insulin. Now, this one doesn't have 3 humps that are the same. This one does, because a lot of times what we do in the hospital is say, well, let's give you a consistent carbohydrate diet. So I know that you're always going to get 60 grams of carbohydrate on your tray, and so we can figure out if you're going to get 60 grams, then within a day or two of looking at their sugars, we can, we make an original calculation based on their total daily dose or based on their body weight, but then we can fine tune it. And maybe that person needs 5 with every meal, with every 60 grams instead of 4. Other ways to do it, and you guys see this too in the hospital, in people who are on the diabetes self-management plan, where they'll calculate their own rapid-acting doses based on their carbohydrate intake, and so you're going to have different amounts of rapid-acting because they're going to eat more or less, and then insulin pump is, at least as an outpatient, the gold standard way, I think, to do it. So if the person is not eating, really you don't need to change your basal insulin if you're using once a day basal insulin. If you're using an intermediate acting insulin, NPH, either half in the morning, half in the evening, or 2/3 in the morning, 1/3 in the evening, remember you're going to have a little bit of a peak with those insulins, and so you're going to have to reduce your dose a little bit, your basal dose a little bit, because otherwise you may get hypoglycemic. And then they're not going to be getting prandial or nutritional because they're not eating, but you're still going to give them correction insulin. And the difference between rapid acting and regular is because longer half-life of regular than rapid acting. And so here's an example. If this person, they get their basal insulin 30 units every day, but their NPO all of a sudden, so they don't get their 10 units for these 2 meals, but they still do get a unit of correction insulin. And then for supper, they're back, and so they get 10 units for their meal, 3 units for their correction, and 30 units for their basal. Versus if they were on an NPH instead, you're probably, because of this peak here of the NPH, you're probably going to have to reduce the NPH in addition to holding the mealtime insulin. If somebody's on continuous tube feeds, I've had people sometimes say, well, why don't we just put them on, once a day long, 24-hour basal to match their continuous tube feeds? Well, the reason that you don't do that is because if you're giving somebody a whopping dose, 80 units of glargine once a day, which covers their basal and their nutritional insulin requirements, what happens when that tube feed gets shut off, or when the tube comes out or whatever? They're going to have this high level of insulin in their blood, and they're going to come crashing down. So while that looks like it might be a good way to do it with just 1 shot a day, it's really not a good way to do it, because you get stuck, because we all know that tube feeds get stopped when you're not ready for them to all the time. So you're still going to use basal insulin, about 50% of the total daily dose. Same things we've talked about each of the other 2 times. And then you're going to divide up their prandial insulin. And so you could give them rapid-acting insulin every 4 hours with the other 50%, or regular every 6 hours. And the nice part about this is that tube feeds, you can write orders, and you can have orders in your sets that if tube feeds get stopped, or if for any reason, then you actually hold the prandial dose. So you don't give them the nutritional coverage when their tube feeds stop. And you can still always, even in that setting, you're still going to give them the correction insulin, but just not the prandial insulin. If somebody's on bolus tube feed, so they're getting 2 cans of Gevity 3 times a day, then that's really very much like you would do with just a person who's eating 3 meals a day. And so this is basically the same. So I won't. All these slides are all starting to look the same, aren't they? Nighttime tube feeds is a good one that I've seen a lot. Nighttime tube feeds grazing during the day. Some of the CF patients, sometimes I see that in transplant patients who aren't eating well. And so this is one time that it's actually better to So here's what their insulin requirement might look like. Here's where the tube feeds start, and their insulin requirement's way up overnight. Then the tube feeds get shut off, and then you have this fluctuating stuff during the day because they're grazing a little bit. And so here's a good time to use NPH in regular because you can give big doses of NPH to cover their overnight tube feeds. You're going to give them a shot of regular at the start also, because otherwise you're going to be hyperglycemic for several hours after you first start the tube feed, so that helps keep that at bay. And then during the day, you can give them a little bit of regular and then NPH to cover the grazing during the day. If somebody's on TPN, most of the time it just, you put insulin in the TPN bags, but you can also still divide it up into basal and correction insulin as well if you want to. High-dose glucocorticoids is sort of the one time that you probably are going to get further away from the 50-50. So in that, as sort of a typical person might need 30% of their dose as basal and up to 70% as prandial nutritional. And here's the graph, look at that, because when you have high-dose prednisone in the morning, your insulin requirements go up during the day. And so here you might do the NPH and regular thing again with a big shot of regular with the supper, NPH, a lower dose of NPH overnight, regular in the morning, and a higher dose of NPH here to sort of more closely mimic what's happening during the day. Another way to do it would be basal insulin that's about 30% of the total daily dose, and then you just increase your mealtime doses to go along with the increased insulin requirement during the day from the prednisone. And then the last one, and this one I actually have a patient who is on this. She gets her prednisone. She's 5 or 10 years out from a kidney transplant, and her nephrologist has her taking prednisone every other day. And, really wreaked havoc on things to try and fix that. And so what we did was we actually, whenever she takes her prednisone, she actually takes a shot of NPH that morning to give her the extra that she needs due to the prednisone, rather than trying to every day, increase her rapid acting or every day increase her glargine to match it. She's actually, it's not exactly this case because she's on an insulin pump. So we had originally tried, well, every day change your pump settings, to pattern A and pattern B, and that was just a real pain for her to do. And it's much easier for her to take a shot of NPH every morning when she takes her prednisone and not do it when she doesn't take her prednisone. So some of these things are pretty cool, I think. Correction doses of insulin, the only reason I have this slide up here is because people need different amounts. So your 140-pound type 1 diabetic has a vastly different correction dose requirement than your 350-pound really obese type 2 diabetic. And sometimes, I think even in this hospital, the generic sliding scale comes up, which is 1 unit for every 25 over 100. And so, if I was there myself and my sugar was 200 and I got 4 units of rapid acting insulin, I'd be 20 within a couple of hours. So, but, my neighbor who's 380 pounds, probably that 4 units is not going to touch him very much. So you sort of need to have a sliding scale or a correction insulin that is more matched or tailored to the patient. So what do you do when you're following these people? And the idea behind this too is that you're going to want to look at these sugars every day and make corrections every day based on what happened the day before. So if they are hypoglycemic, what happened? Did they get the amount as ordered? Did they get their rapid-acting insulin and then the tray didn't show up for an hour and a half? Did they get made NPO, but they still got the rapid-acting dose? So there's a lot of things. So whenever you see these excursions, you really need to investigate and figure out what caused the excursion. And most of the time, there's going to be a reason. If there's not, then your dose calculation is wrong and you need to cut back on the dose. But more often than not, there's a reason. And then you have to go back and educate, whoever is responsible for the reason. Again, education. The example here is that the nurse might know the patient's NPO, but she sees the 6 units of aspart ordered every morning, and she gives it anyway. And then you might go back and say to her, she's NPO, and this orders say hold, scheduled aspart if patient is NPO. And so with the more you point these kinds of things out, the better people do long term, I think. So if somebody's hyperglycemic, again, here you want to investigate and find out what happened. I think historically the nurse calls somebody, calls the covering intern at 10 o'clock and says, Mr. So-and-so sugar is 100 right now. He's supposed to get 30 units of glargine. Should I still give it to him? No, don't give it to him. Or okay, we'll just give him half. and then the next day his sugars are 250 or 300. So you got to actually go back and look at the chart and find out why. If you don't find or maybe they got started on, D5 or D10 or something like that, or maybe they got started on prednisone. So, go back and look and review things and then make a change based on it, or educate whoever made the mistake, that intern who said, hold the glargine. So you want to look at things, and again, I don't need to go through this, changing it. Another thing that I think people get sort of missed or messed up on is like my patient that I presented earlier. He got sent home on 60 units less of scheduled insulin a day than he was on when he went in, and it translated into an A1C going from 7.2 to 9.8. So look at what they were doing. So if this person's A1C, well, this one's new hyperglycemia, but the same point applies. So if the person's A1C was pretty good when they came in, then you could probably send them home on what they came in on. If their blood sugars were high, so again, jump to slide. So here's the one I'm talking about now. So if they were high when they came in, if their A1C was 8, 9, 10 when they came in, then you probably ought to send them home on a more aggressive regimen than what they were on when they came in. But if their A1C was 7 when they came in, you probably just want to send them home, unless you're sending them home on steroids or something like that, then you probably want to send them home on what they were on before, be that insulin or oral agents. But for people with newly diagnosed hyperglycemia, like that earlier slide I showed with the 12% of patients that it was new, what was their A1C when they came in? And if it was 8, well, you know what? They have diabetes, and you need to tell them they have diabetes, and you need to address it and have a plan and a follow-up plan. If their A1C was 5.2, then they probably don't have it, and it's just related to the stress of their illness and plus the IV glucose they were getting and other things. 5.2 to 6 could be either way. But most of these people need close follow-up, and that's another thing, I think that gets fallen through the cracks, is that people don't reinforce to the patient or don't arrange for follow-up of their glucoses when they go home. So this is actually, so I've quoted Umperes multiple times. If you don't know, he's one of the big names in inpatient glucose control. But he and some other investigators looked at a couple of hospitals in Atlanta and in San Diego, and they just reviewed charts. And what they found, they said, these are sort of good hospitals in these two areas of the country, so these things probably apply to most hospitals. And so what they found is that a third of the patients with hyperglycemia average their blood sugar over 200. So again, at least a third of patients that are in the hospital with hyperglycemia are not well managed. Most of them get put on a sliding scale only. 10% of them have one hypoglycemic event, and discharge plans include follow-up of hyperglycemia only a minority of time. I've seen this before, and I'm sure you guys have too, that somebody just recently gets diagnosed with diabetes by their primary care doctor, and I find out, well, they were admitted to they get referred to me, and they were admitted to UNC 2 years ago. And when I look back, on their chem panels, they had 2 or 3 glucoses that were 240 or 300 2 years ago, but nobody ever mentioned that in their discharge summary, and nobody ever followed up on it. And so that often gets missed in today's world. How am I doing time-wise? Perfect. So in summary, glucose control in the hospital is important. There's recent debate with respect to goals, however, and we talked about that. And so I think right now, both in the in the critically ill and the non-critically ill patients, you really should be shooting for 140 to 180. But I saw a presentation at the ADA just a couple weeks ago that they had a panel, of experts on it, and they said, and the people were complaining because they said we've got these protocols that do really well, which have our patients' blood sugars between 110 and 140. Why should we loosen them up and make things worse? We don't have a lot of hypoglycemia. We're doing great. And so they have so their sort of subtext says, but if you're doing well, you don't have to change it. You're still okay if you have them, 110 to 140. But you really shouldn't be letting people run 180 or higher is the bottom line. Physiologic insulin regimens work best. Review glucose results daily and adjust. And make glucose control and diagnosis of diabetes part of your discharge planning. And there's still obviously quite a bit of study needed. So I told you, that we were going to start this new inpatient diabetes management service where we're going to basically, an attending is going to spend half a day or more in the hospital with the team every day. It's going to be staffed by 2 attendings. One of them is me, one of them is Steve DeCharney, who's sitting right there in the
fifth row. We're going to have a nurse practitioner working with us, endocrine fellow, of course, residents, students, hopefully an educator. And our goals are going to be, number one, improve patient care. You know, and my real goal is I don't want to see what happened to my patient happen to other people in the hospital. But help transition follow-up of glucose, glucose follow-up as an outpatient as well, so people don't get lost through the cracks for 2 or 3 years, or they don't get sent home on regimens that are inappropriate for them because nobody bothered to look at the admission regimen, and educate. And the educate doesn't just mean patients, it means staff and house staff and physicians and nurses, pretty much everybody. And that's it. So we got a couple minutes left for questions that anybody might have.
Starting insulin, you know, they fear having to go on it once they leave the hospital. So we'll have discussions you have with them, and then when they leave the hospital, especially if they've been hyperglycemic or heart control, what do you do in terms of their oral agents you were on to begin with?
So that's where the A1C, you know, the admission A1C can help you. So like I said, if that person's A1C on admission was 8, 8.5, 9, 10, then they need advanced therapy. You know, they need to advance their therapy. You shouldn't send them home on the same thing. As far as starting insulin on people that are admitted, I haven't seen that as a problem most of the time because these people are sick, they're in the hospital, they're getting poked all the time. What's a few more pokes? But the harder one would be, you know, well, I'm going home, you're going to send me home on insulin. And there I'll sort of, oftentimes the best example is in the heart attack, you know, the post-MI patient where you say, look, there's good data that if we keep you on this aggressive regimen, it'll reduce your risk of death by 25%, you know, and other people who are in post-surgery, you know, well, we know that wound healing and infection is less if we maintain your control tightly. So you're right, sometimes it's hard to talk people on, but you have this point of time where these people are ill, you know, something bad has happened to them or they wouldn't be in the hospital, and so sometimes you can use that to help convince them or get them to do better from a diabetes standpoint. So.
When do you fit a dietitian into this program?
Yeah, so we actually had a meeting about that, and we're hoping to have a diabetes educator who works closely with our team, either diabetes educator or a nurse educator, who will help us and help do that. But it would be a very beneficial thing to have somebody who can educate the patients. You know, if we round on each patient for 20 minutes or 15 minutes, there's a limited amount of education that we can do, but if there's somebody else who can spend 30, 40, 50 minutes with that person, start showing them how to do insulin, you know, talking to them about diet and stuff, that would be very helpful. So we're hoping to have that. Right now it's left to the nurses on the floors to do it, and so some of them I'm sure are very good, some of them are not probably as good, and but they've also got all these other responsibilities because they may have 4, 8, however many patients they're covering right then and there. So, so I think it would be beneficial for the patient if there was somebody who was specifically, that was their job to help with education and dietitian and stuff, diet and stuff.
I just want to plug for the diabetes resource nurses. There's 200 in our hospital, so you could ask on the unit they work on if there's any resource nurses working in it.
What patients do you expect to follow with the service? All patients with diabetes?
No, you know, what I would say is, you know, so if you bring your patient gets admitted to your service and you spend a day or two and you can't do it, call us. Or, you know, if that person comes in and their sugar's 400 and you're like, I don't know what to do, you know, I don't want to mess with this, then call, you know, we're happy to see anybody. Or if they come in on a pump, call, you know, I can't expect you guys to know as much about pumps as we do because we do it all the time. So anybody that you know, if you bring the person in and their sugars are doing great, or, you know, you don't have to call us. We don't want to see everybody. You know, this is a 700-bed hospital, and at any given time, there's probably 200 diabetics here. And we've talked about, you know, if the service grows to 30, 40, 50 patients, we'll probably have to add more and more nurse practitioners or, you know, other providers to help. So. Right, and you know, it's part of what started all this for me was when I was at that other institution that's local. They have a phenomenal inpatient diabetes program, and they rounded on, they had a team like we were trying to assemble, and they rounded on 20 to 30 people a day. People really loved the service, the residents, because they got a lot of learning and teaching. But we did a really good job with the patients and educating them and, getting them on track. Sometimes they followed up with us. Sometimes they're from 2 hours away. As part of this new service, I'm going to try to arrange, at least a follow-up clinic. So for people that need, a one-time quick check, they can come back and see us, and we'll have some saved spots to do that. So they actually started over at Duke. Because it was so successful, they actually were talking, when I left Duke, they were talking about hiring a nurse practitioner whose job it was to, every time an order for a sliding scale got entered, she was going to go just take a quick peek at the patient's chart to see, now it's going to be a lot easier with it being online, but take a quick peek and say, does this person really need a diabetes management service consult? So we're a little ways from that. We want to start the service and make it successful, and then if it's really successful, then we may do stuff like that in the future.
I don't know that matters, because we can manage it either way. So I think it's up to the patient. If you think the patient can do bolus rather than slow drip continuous, whatever is better for the patient, because we can manage their sugar either way. If you do it right, you can. All right. Well, thanks for your attention.